Today, I'm going to talk to you about decision-making and controversies in the use of gastric acid suppressants. Just a reminder that the opinions expressed by myself don't necessarily represent or reflect the views of Nestle Purina or its affiliates. And I do need to acknowledge that I have a conflict of interest related to this presentation. I'm a scientific advisory board member for Trivium Vet that's trying to bring an omeprazole product to the US through an FDA approval process. But I think you'll see that this doesn't actually impact what I have to tell you about the use of proton pump inhibitors, which largely is going to be to think before you use them. So again, we're going to talk about decision making in the use of gastric acid suppressants and when to think about that. So the first thing being, is there an appropriate indication for the use of the gastric acid suppressant? And if so, or if you're unsure, what objective measures are you going to use to actually determine if a beneficial effect is achieved? And finally, if you're going to start the administration or recommend the use of an acid suppressant drug, have you actually provided adequate instructions for the use of that drug, as well as discontinuation of the drug? Because we know that acid suppressants are obviously available over the counter, and the client will continue oftentimes beyond the length of the prescription that you provided them if you don't provide them adequate instructions for discontinuation. So as I've already alluded to, I think the way that we effectively use gastric acid suppressants most of the time is actually not to use them. We know that gastric acid suppressants, much like we've discussed with antibiotics, are one of the most overprescribed drugs, both in human and veterinary hospitals. And indeed, one of our former interns, now a medicine resident at UPenn, Samantha Duxbury, did this study where she did a cross-sectional observational study of tertiary care veterinary teaching hospital, where she looked over a 5-year period to see what the administration of acid suppressants looked like in our hospitalized patients. And probably no surprise to anyone to see that they're quite commonly used. They're administered to 40% of hospitalized patients. And then when she randomly selected 250 prescriptions from those patients that were containing proton pump inhibitors, she analyzed them for appropriateness. She found a few kind of shocking things, which were that 75% actually weren't used at the dosage that we would recommend for the treatment of ulceration or esophagitis. 90% actually didn't have administration instructions, such as to administer if you're administering it orally on a fasted stomach, for example. 50% of prescriptions that went home had no guidelines for discontinuation of the drug, and then 65% actually didn't really even have an appropriate indication. Which brings us to discussing, well, what are the appropriate indications for the use of these drugs? And we hopefully all know that there is a consensus statement where there has been guidelines for the use of these drugs. And so in that consensus statement, you'll find that the indications for the use of gastric acid suppressants are with documented or suspected upper GI bleeding or ulceration or erosion resulting from either GI or pancreatic neoplasia, ulcerogenic drugs such as NSAIDs and Palladia. We're going to talk a bit more about the use of PPIs with NSAIDs. Inflammatory bowel disease or chronic inflammatory enteropathy, severe stress-related mucosal disease, upper GI foreign bodies, and esophagitis. And again, I think that the most important term here that I've underlined is documented or suspected bleeding. That's the most important thing to make sure that you have a suspicion before you use these drugs. So in terms of consensus conclusions about acid suppressants, I think we all recognize that PPIs, proton pump inhibitors, are superior to histamine 2 receptor antagonists in both dogs and cats, and that ranitidine is not an effective acid suppressant in either species. The other thing in the consensus you'll find is that PPIs largely need to be administered twice daily when treating severe ulceration or esophagitis. Now, this was challenged recently in a paper out of the Journal of Veterinary Internal Medicine in 2017, where these investigators did both a pharmacodynamic study and a pharmacokinetic study looking at esomeprazole. So esomeprazole here, they administered to, I believe it was 7 healthy beagle dogs. And then they looked over time with different routes of administration at the mean percentage time, so MPT, that the intragastric pH was a minimum of 3 or 4 for 24 hours. And they looked at either baseline, where there was no drug, intravenous administration one time, subcutaneous administration one time. Both of those were at 1 mg per kg, either IV or sub-Q, and then orally administered for 5 days. And then they measured the intragastric pH on day 5. And again, these patients were administered the drug at 1 mg per kg once a day. And the surprising thing from this study is that you can see actually the 1 mg per kg once a day dose, either subcutaneously or orally, actually achieved the goals for the treatment of ulceration and esophagitis, at least as defined for humans, that we think is an appropriate goal for dogs as well. And so this got a lot of attention and led us to believe, well, maybe esomeprazole is a bit different. We know it's more potent than omeprazole, so maybe you can administer this drug once a day. But this was followed by a study that has not been published, but was presented at the ACVIM Congress in 2023 by Abby Astronic and Dr. Emily Gould. And in this study, they took 9 healthy dogs that weighed at least 20 kilograms, and they had them receive both actually 0.5 or 1 mg per kg in a crossover design of esomeprazole once a day. And what they found was that 33% of these dogs actually didn't achieve the goals for acid suppression with either once daily dosage. So this is a little bit different than what has been published in 2017 and does give me pause when thinking about using esomeprazole once a day, at least when administered orally. When they then took these dogs, and for the dogs that didn't meet the goals of once a day therapy and gave them twice daily therapy, then they were able to reach the goals for the treatment of duodenal ulceration and esophagitis. I think the clinical take-home point here is we find that esomeprazole, in my experience, is a more potent proton pump inhibitor, just like it is in humans. If I have a client who I think may only administer the drug once daily, despite my recommendations to administer it twice daily, those are the cases where I definitely would choose esomeprazole, but I would still make the recommendation that they administer it twice daily. So again, esomeprazole is probably superior to omeprazole when orally administered at the same dose and frequency, although that study has not yet been performed in dogs. My experience anecdotally is that esomeprazole causes a bit more side effects than omeprazole in terms of vomiting and diarrhea in dogs. And there was a study actually by a few investigators at the University of Wisconsin, Ray McAtee, as well as Dr. Sarah Schmid, and they found that side effects were present and unfortunately not improved by the co-administration of probiotics. So that was a common thing that I would say is that, okay, if you see side effects, maybe if you give a probiotic alongside, we'll see less vomiting and diarrhea in dogs. And unfortunately, that was not the case. So for me, the clinical take home here would be that if you do see side effects that develop with either omeprazole or esomeprazole, those are the cases where I would cut the dosage, meaning that I would take it down to even a subtherapeutic effect for a few days, maybe 1/4 of a mg per kg once a day, and then slowly increase over time to get to that dosage. That has worked for me in a few cases, not always, but I think that's something that we can try if you feel like there's an appropriate indication for the use of the drug, but the side effects are preventing you from using it effectively. The other thing that we've learned since the consensus statement is that the effect of different types of proton pump inhibitors may be quite variable. This is a study that we performed in 2020 with a resident at the time, as well as Deslo Odunayo, who's a criticalist at University of Florida. And in this particular study, we took cats and we had a cross-sectional crossover design where all cats received all treatments, so they served as their own controls. And on the y-axis here, you can see mean percent time the intragastric pH is at or above 3. Again, remember that the goal is that red line, which is to get all of those figures above 75% of the day. On day 0, that's when the cats are receiving no drug, and then over time they're receiving the drugs, either dexlansoprazole, which you can see as the circle here, a square, which is S-omeprazole, and the downward triangle, which is lansoprazole. And so what we can see is a few things, both with dexlansoprazole, which is meant to be sort of a longer acting proton pump inhibitor in people that has sort of a dual mechanism of action where it's supposed to be immediate release and then have a delayed release. We can see that both dexlansoprazole and esomeprazole take some time to reach maximal effect. That's pretty common with proton pump inhibitors, both in dogs and cats. However, my clinical experience is that proton pump inhibitors are as effective as a histamine 2 receptor antagonist on day one. It's just that the proton pump inhibitor will be even more effective than the histamine 2 receptor antagonist over time. So what we can see here is that both dexlansoprazole and esomeprazole outperformed lansoprazole. And we can see that actually lansoprazole, I don't have it pictured here, but either when administered as a capsule or in a few cats, we gave it as a suspension just to prove that this was the case. Lansoprazole was not an effective proton pump inhibitor in cats, and we don't really know why. It could be something about the cytochrome P450 system working differently with lansoprazole as compared to the other drugs. We don't really have a good explanation, but it's important to recognize here that we can see that the different proton pump inhibitors have different effects. And for these cats, it was true again that esomeprazole was the more potent proton pump inhibitor. The same is also true in dogs when we look at different acid suppressants and in particular proton pump inhibitors. So again, here what we can see is on the y-axis, mean percent time the pH is at or above 3. The horizontal red line is our goal. And again, day 0 is when dogs are not receiving any treatment, followed by 3 days of treatment. This open circle, or excuse me, this closed circles are pantoprazole. The closed squares are esomeprazole. And then the downward triangle this time is a famotidine CRI. So the famotidine CRI, we give a 1 mg per kg IV bolus, and then follow that by an 8 mg per kg per day CRI. And so what we can see here, again, just like we saw in the previous graph in cats, this time this is in dogs, where we can see at times pantoprazole is actually not a very effective proton pump inhibitor for dogs, whereas esomeprazole seemed to be a very potent, effective acid suppressant. And also we see that the famotidine, when administered as a high dose constant rate infusion, is a very effective acid suppressant in dogs. So other things that we've learned since the consensus statement, again, I just showed you that histamine 2 receptor antagonists, i.e. famotidine, is more effective when given at high doses as a constant rate infusion. We also know since the publication of the consensus that histamine 2 receptor antagonists are pretty effective during the first few days of at least oral administration, but then become less effective with repeated oral daily administration. And we can see that here. This was a study that we performed in 2018, and it was funded by the Every Cat Health Foundation. Same sort of idea with this figure as we've seen before, where the mean percent time the intragastric pH is at or above 3 is on the y-axis. Treatment over days is on the x-axis. Day 1 is a day where they're receiving drug. So what we can see here, in contrast to what we see at least in dogs, is that the potency of orally administered famotidine, at least at 1 mg per kg twice a day, it is an acid suppressant. We do see an effect, but it's certainly not as potent as what we see in dogs. And then what we see is that over time, the effectiveness of the famotidine when orally administered wanes. So it does have a diminished effect in cats over time. And also here we can see a schematic from a study that we did in dogs where we saw the same exact thing. In this case, we could see that on day 1 and day 2, orally administered famotidine at 1 mg per kg twice a day was quite effective, very potent, but by day 3, it had a diminished efficacy. We don't know if the same thing happens with IV administered famotidine. So people commonly ask me, well, what about the CRI of famotidine? If you go beyond those 3 days, do you see diminished effect? And in people, you do. So if you go beyond 72 hours with a CRI of famotidine, you start getting sort of diminished returns. We don't know if that's the case in dogs and cats. I suspect it probably is over time, but when it starts diminishing with IV use, I'm not really sure. So in terms of how to use famotidine effectively, we're going to limit the oral use to short term, meaning that maybe for symptomatic control or when you don't need really aggressive acid suppression, such as in the case of bilious vomiting, then maybe the chronic use of famotidine in this case is fine. It provides fair in cats to excellent, most dogs, acid suppression on day 1 and day 2 of twice daily orally administered famotidine. But again, over time, there's this diminished effect. If you only have famotidine at your disposal and you have a really significant GI ulceration, that is the time where I would use a famotidine CRI or use something like esomeprazole to provide really effective and potent acid suppression in the hospital. Other updated consensus conclusions about acid suppressants. The thing that we actually did include in the consensus is that histamine 2 receptor antagonists should not be used in combination with proton pump inhibitors when aggressive acid suppression is desired, because what we showed is that there seems to be maybe a bit of a diminished effect, and that has to do with the pharmacodynamics of the proton pump inhibitor. Here we can see again, y-axis, mean percent time, gastric pH is at or above 3. X-axis is days of treatment. The closed circles are pantoprazole alone. Open circles are pantoprazole when co-administered with famotidine, both at 1 mg per kg, IV administration twice a day. And so what we can see for sure, at least, is that there doesn't seem to be an added benefit. There's not an added benefit of putting famotidine on top of pantoprazole. And over time, this was underpowered, unfortunately, to answer this question, but there is a trend towards the addition of famotidine maybe even being harmful to the action of pantoprazole. So when you are using an acid suppressant because you have severe sort of esophagitis where you think there could be the development of a stricture or there's quite significant pain, or when you're treating gastric ulceration or proximal duodenal ulceration and you want maximal acid suppression, in those cases, you should either use a famotidine CRI or you should use a proton pump inhibitor, but you shouldn't use both. There are times where you might use both together, and that is the one time where you have pretty severe gastroesophageal reflux disease. And in those cases, you're using your proton pump inhibitor twice a day, and you're typically giving famotidine just at nighttime to help with nighttime acid reflux. But that is the one time where you might be co-administering the drugs. Other times where you just want really aggressive acid suppression, you should use the proton pump inhibitor alone or the famotidine CRI if that's available to you. So what are the adverse effects to worry about in terms of short-term proton pump inhibitor use? Certainly GI signs. So in cats and dogs, they both can have vomiting. So I usually warn the owners about that. Of course, you can have pretty significant diarrhea in dogs. And then, you know, we've shown in our lab, and Jan has also shown in dogs, we've shown this in cats, that this can cause a transient dysbiosis. And I know Jan talked about that yesterday as well, where if you apply the omeprazole or administer omeprazole to a dog or cat, we see this transient dysbiosis. But unlike with antibiotics, if you stop the proton pump inhibitor, the dysbiosis seems to disappear. The other thing that I often worry about with the use of proton pump inhibitors or any type of gastroprotectants is compliance. Oftentimes when we're using these drugs, we're also giving many other medications. And the last thing I want to do is to add on a drug that I think won't be beneficial or I'm not sure will be beneficial, that then takes the client away from other drugs that they might administer. So in the case of, for example, IMHA, where they're giving a steroid, we definitely want them to get the steroid. I'm less convinced that they actually need the omeprazole, which we're going to talk about. The other thing that I've put in a question mark is bacterial pneumonia. So remember that acid is a really important barrier towards the ingestion of microorganisms. So, right, it's important for the neutralization of microorganisms. So if we have a case where we have a dog or a cat in the hospital, obviously they're very susceptible to the development of nosocomial pneumonias. And in those cases, I'm really worried about taking away the barrier that they have for preventing that in a vomiting animal. So in these cases, I definitely would not use a proton pump inhibitor unless it was really something that I felt was indicated. Those are the cases where I would really rely more on my antiemetics than anything else. So when are acid suppressants not indicated? Certainly for prophylaxis for NSAID therapy in the absence of other risk factors for GI bleeding. So we know that proton pump inhibitors are the treatment of choice once NSAID-induced ulceration is noted for ulceration of either the stomach or the proximal duodenum. But remember, in those cases, the NSAID is discontinued and then the proton pump inhibitor is started. And the reason for that is that proton pump inhibitors are not recommended for prophylaxis with NSAID therapy, even in humans. In young healthy humans, there's a study where they had healthy humans take both an NSAID and a proton pump inhibitor at the same time for 2 weeks. And then they compared that to humans that were taking the NSAID with placebo. And what they found was that there was a high incidence of mid and distal small intestinal damage and bleeding in the groups that received both the NSAID and the PPI as compared to the NSAID with the placebo. So we can see that the co-administration of NSAID plus PPI appears to cause harm. So for that reason, we do not recommend proton pump inhibitor prophylaxis with NSAIDs. And we did a study as well. Susie Jones and Ann Geyer at NC State, along with Kristen Messenger and myself and Mark Papich and Jan Sukoldowski, did a study where we looked at the co-administration of proton pump inhibitors and NSAIDs in dogs. And these are the results. So this was healthy beagle dogs and hound dogs where we looked at their dysbiosis index. And I know that's been talked about quite a lot, so I'm not going to take the time right now to talk to you more about what the dysbiosis index is. But briefly, what we can see here is on the y-axis is the mean dysbiosis index. This was a sequential design. So all dogs served as their own control. They received baseline, followed by carprofen, followed by carprofen plus omeprazole, and there was a washout period in between. So this is day 5, 6, and 7 of each of those therapies. What we can see is that baseline, so where they're receiving no treatments, is the closed circles here. And then the closed squares are carprofen alone at 4 mg per kg once a day, so kind of a standard dose. And we can see that these dogs remain normobiotic, so they continue to have normobiosis. But when you then give them omeprazole along with their carprofen, and the omeprazole was administered at 1 mg per kg twice a day, we can see that we do indeed induce a dysbiosis, which has already been shown before. However, when we look to see if are there any consequences of that dysbiosis, we can see that there are. So here what we did was we measured their fecal calprotectin, and that was basically an indicator of fecal inflammation. And so on the y-axis here, you can see the calprotectin concentration when dogs are at baseline, so they're receiving no drug, or they're receiving carprofen, again, at 4 mg per kg once a day, or then they're receiving carprofen with that omeprazole. And so what we can see is there's actually no significant difference in fecal inflammation when comparing no treatment to carprofen. But when you add on that omeprazole, then we induce inflammation in these dogs' feces. So again, we're causing harm even when we think we're actually providing a benefit. There's another study that was published recently, so 2021. I believe this study was out of Purdue, and this was a prospective randomized placebo-controlled study looking at cancer-bearing dogs that were receiving the NSAID piroxicam, and they were treated with just piroxicam alone with placebo or in combination with omeprazole and famotidine, and they graded the adverse effects using this Veterinary Comparative Oncology Group's common terminology criteria for adverse events. So in this schematic, if there's no box, it's so white, that's no adverse effect. A light gray is a grade 1 adverse effect. A medium gray is a grade 2 adverse effect, and then black is grade 3. And I'm not going to go through all of these adverse effects. You can see there's a variety of different things along the possibilities of GI adverse events. But I think it's pretty clear when you look at all these dogs, again, cancer-bearing dogs receiving piroxicam with or without placebo, omeprazole, or famotidine, what we can see is that there's a significant difference. There are more adverse effects when dogs received famotidine with a piroxicam, and even more so with omeprazole and piroxicam than when they received placebo alone. So indeed, we're inducing harm when we use an acid suppressant prophylactically in these dogs that receiving an NSAID. So we don't recommend that. The one time where you might consider using PPI prophylaxis in these animals, if there are additional high risk factors. So in people, that includes things like pretty severe heart disease where you have poor perfusion to the gut. You already have had a history of gastric or duodenal ulcers with NSAIDs, but there's a need to continue the NSAID. Those are the cases where they might think about it. Or if you have a double hit, so something else that's really injuring the gut, like mechanical ventilation or dual coagulopathy, along with using the NSAID. So very specific and narrow indications where they might think about PPI prophylaxis in this group, because again, they recognize that you have the potential to actually induce harm. We don't really know what the indications are for dogs and cats when they're receiving NSAID, if we should consider PPI prophylaxis. But again, I think based on this list that we can see with humans, it's very uncommon that we should be thinking about that. And really, we need to think about the added expense, again, the compliance issue because of pill burden, and the potential for some pretty serious adverse effects in these animals. I want to make sure it's very clear that obviously in the case of NSAID toxicity, we would absolutely use proton pump inhibitors for those cases. But again, in that case, you would stop the NSAID and you would start the proton pump inhibitor with or without misoprostol. The other thing I'm commonly asked about is prophylaxis for steroid therapy. There is a study actually out of the University of Tennessee that looked at this. They took healthy dogs and they gave them high doses of prednisone with or without omeprazole, placebo, or a probiotic. And this is the results of that study, where they looked at their total gastric mucosal lesion score, basically injury to the gut, and then over time of those various therapies. And if we just pay attention to this day 28 here, what we can see is that there was actually potentially, although there was a pretty wide deviation among the groups, as you can see, there does appear to be somewhat of a healing effect with omeprazole as judged by traditional endoscopy scores, where dogs that received high-dose prednisone with omeprazole did seem to have lessened gastric mucosal lesion scores as compared to dogs that received prednisone or that received prednisone with probiotics. But in the end, and I encourage you, I know this is a very busy figure, I encourage you to pull this paper, there wasn't really a significant clinical effect of the use of prednisone in these dogs. They didn't really have a significant any significant evidence in terms of fecal occult blood, melena, hematochezia. They didn't really have severity of their anemia, and when they received the omeprazole, it wasn't necessarily preventative in any of the development of clinically significant bleeding. So in these cases, I still think, despite this paper, we should think more about the use of omeprazole, even in the case of steroids. I think steroids, yes, are indeed erosive or ulceronogenic to the stomach for sure. Are the erosions or ulcers often clinically significant? No. Yes, we can all think of those cases where we had pretty severe GI bleeding with steroids, but for the most part, they're generally not clinically significant. And we still don't know, do PPIs actually help with clinically significant ulceration? So if you have those cases that have severe GI bleeding that are really dropping the hematocrit quickly, does a PPI help in those cases? We don't know. That has not yet been answered. So I would continue with consensus guidelines to use prophylactic PPI only when additional risk factors for bleeding or documented bleeding occurs. And ideally, in those cases, you would either discontinue or at least lower the steroid dose if you could. Finally, I want to wrap up with prophylaxis for acute thoracolumbar intervertebral disc extrusion, because that's another one that I get a lot of questions about. We have done several studies looking at this. This was a study from Dr. Melissa Lewis when she was at Purdue. It's a double-blinded, placebo-controlled prospective trial investigating the use of omeprazole in dogs that presented for acute thoracolumbar IVDD that were undergoing surgery. And in this particular case, we didn't find any significant difference in evidence of bleeding, whether a dog received omeprazole or placebo prior to and during or after surgery. And just like I showed you with the piroxicam paper in cancer-bearing dogs, the dogs that received omeprazole often had more diarrhea as compared to dogs that received placebo. So again, just a reminder that although the adverse events are not as harmful as some of the things we talk about with antibiotics, there are still adverse effects to worry about. The big one, again, being compliance, and then some adverse GI effects that I've already talked about. So in thinking about sort of the clinical indications in decision-making and acid suppressants. Again, the questions that you want to ask yourself is, one, is there actually an appropriate indication for the use of the drug, or am I just reflexively using it because the animal is presenting vomiting and I want to do everything possible to control the vomiting? In those cases, I would say a vomiting dog or a vomiting cat, there's not an appropriate indication. You should try your antiemetic therapy first and try to treat the underlying disease. But if you're not sure, like you're not sure if there's an appropriate indication or not, because maybe you have evidence of sort of a microcytosis with an anemia, and you think maybe there could be a chronic GI bleed, then it's appropriate to go ahead and use the drug and make sure that the clients know that they absolutely have to be compliant to get the maximal effect. But then make sure you've outlined what objective measures that you'll be using to determine if a beneficial effect is actually achieved. And finally, make sure to provide adequate instructions for use and discontinuation of the drug with a reasonable length of time for assessment. If you're treating microcytic anemia because you think there's a GI bleeding, given the drug for 7 days is not an appropriate length of time. You really have to allow for the body to actually heal the bleeding and have a regenerative response. Okay, so with that, I think I'll go ahead and stop sharing and see if there are any questions that I can address.